A few technical, simple messages about MRI and CT angio. And I will focus mostly on renal stenosis, but we'll show you also some slides in preparation for tomorrow on the adenoma imaging technique. And I will not cover it up, like this has been extensively discussed. So, of course, when we do imaging, whether we are a radiologist or clinical specialist, we focus on clinical information, patient history, hypertension history, clinical examination, and initial standard biological workup, because this will help you to address more appropriately the case of this patient. Second, when you need to do imaging, you will probably choose between CT angio and MR angio, and this will rely on a lot of different things. Some are more scientific, some are less scientific. Obviously, local expertise and access to the modalities is very important. Some countries have very good access to MR, some have less access to MR. The quality of the equipment, if you have the brand new MR magnet, you will be more happy if you have an old CT scanner, and the patient status, obviously. So why do we look for secondary hypertension? Because we know that it's potentially curable in some cases, not so frequently. Renal stenosis, a lot of discussion today. Endocrine reasons, primary aldosteronism, pheochromocytoma, and other reasons. And of course, on the top of that, some cases do require specific radiologic follow-up, like non-tumoral primary aldosteronism or renal stenosis or chronic renal disease. So whom should we screen for secondary hypertension? This question has been already addressed briefly. Adults with severe hypertension, drug-resistant hypertension, this is the international consensus, many of them. We don't speak about children. And on the top of that, if you have clinical or routine laboratory evaluation that suggests that there is a cause for secondary hypertension. Curable and incidence and prevalence of disease is summarized here from the literature. If you have pheochromocytoma, you can cure a lot of patients, but it's not a frequent disease, but you need not to miss it because it's very important for the future of the patient. Dysplastic renal stenosis, you know that we can cure approximately half of the patient, but we can improve also a significant number of them. Adrenal adenoma, atherosclerotic renal stenosis, with all the controversies that we will expand more on later, and sleep apnea. All these are reasons for secondary hypertension. So, according to the setting where you're working, you will see more endocrine more endocrine reasons or more renal stenosis. This is different series from the literature. This is from our group. You see that in most of the groups, you see a little more adrenal adenoma than renal stenosis, but these vary a lot according to your setting. So the most frequent reason for secondary hypertension, obviously, is renal artery stenosis and adrenal adenoma. So you have a setting which have already been discussed briefly of clinical signs that will put you in the situation where you think that might be renal artery stenosis. These are listed here. I will not summarize them for the sake of time. And on the other hand, for endocrine disease, hyperkalemia, and sometimes adrenergic symptoms. So let's focus first on renal artery stenosis. So this is a very classical image. So atherosclerotic renal artery stenosis are mostly ostial or nearly ostial, calcified, sometimes bilateral, sometimes post-stenotic dilatation. We don't know exactly what it means, but we can see it on angio, CT, or any modality. FMD obviously is a very important cause to find. It is a correlation between angio, CT, and a conventional angiography. You see that when it's unifocal FMD, you can see very nicely the stenosis. You can probably also give quantification of the stenosis. When it's multifocal spring of beads, you can see it clearly on both modalities. This is the angio, which is obviously the gold standard, but it's very difficult to assess the stenosis, and I will comment a little more on that later. So basic technique, MR angiography is usually contrast enhanced, although there are new technology without contrast, but in summary for today, it's gadolinium injection, so you have to take care of the kidney function, as you know, as well as for CT, even if it's less a preoccupation, and there are some contraindications which can be very problematic, like pacemaker and claustrophobia. 10% of patients cannot undergo MR. CT is obviously now the gold standard CVT detector. Obviously you inject iodine, and on the average you will probably get a higher quality and a higher reproducibility. Post-treatment of the images is very important. Different techniques with these strange words that you know about, MIP, surface rendering technique, surface shaded display, and volume rendering technique, which are good to see and good for the display, not necessarily very good to calculate the stenosis, and a different kind of quantification software using multiplanar reformation, most of them. So this is some short example of coronal acquisition with an MR angiography sequence, gadolinium enhanced. So you do first coronal acquisition, and then you focus additional central axial acquisition on a smaller field of view to have a better look to the stenosis. This is an example of a CT image and what we call VRT, volume rendering technique. This is a now very well-known word by everybody. So you can see that this is a very nice demonstration of what we see in terms of anatomy globally, but to calculate the stenosis, it is not the best technique. Because when we want to calculate stenosis using CT, we need curvilinear reformation. So we start from this image, which is elongation of the artery, and then you have this kind of software which allows you, like with a QCA or QVA, to calculate the minimal luminal diameter here and the normal reference diameter. And I stress here that you have a post-stenotic dilatation, so this is not the normal vessel diameter that you would like to compare to, but we would go probably more distal when there is no post-stenotic dilatation. So when we look at the respective quality and reliability of this technique, this is a famous paper, already 10 years old, but nothing better since then. CT angio, MR angio with injection, MR angio without injection, and scintigraphy, which is not the discussion for today because it's a technique which is not very useful. Obviously, if there is an indication for intra-arterial catheterization, whether it's coronary artery or another peripheral arterial disease that you want to treat, and if there is an indication, then you would go and flush the renal arteries to see if there is a stenosis in this setting, but this is not the topic for today. So if you look at the quality and the sensitivity and specificity of CT angio, MR angio and renal artery stenosis, it's very different whether you look for atheromatous lesion or dysplastic RFMD lesions. Atheroma, good sensitivity, specificity, you see 77%, 94% here, and for MR it's the same, a little less specific, but for dysplasia, sensitivity goes much, much, much down. So you see here, we're not very good. Quantification, it's relatively good when we are looking for atheromatous lesions. It doesn't give any functional information, and you have to rely to duplex. It's good for anti-malfibron muscular dysplasia, but for multifocal FMD, this famous string and bead effect aspect, I would say, CT is not good, MR is not good, and angio is not so good, but not so bad. It's the best technique. So again, the same slide, unifocal, you can measure the stenosis relatively easily with both techniques. This is CT, and again, multifocal string of beads, very difficult to assess if there is a stenosis here on CT, and not so easy on angio as well. So CT and MR does not help you really to quantify the stenosis, and this is a volume rendering technique using CT, and this is an MR imaging of the same patient. So how do we quantify the stenosis? There's an indirect approach. We calculate the number of diaphragm. We try in some cases to take transstenotic gradient during the angio, look at collateral circulation, but there is really no gold standard here. It's not very easy to understand. So I just want to show you a few points on adrenal adenoma if I have 1 or 2 more minutes, and it will be probably more discussed tomorrow, but I think it's good for you to see these images to start with. So clinical goals, this is what we all know. We have to screen in patients with hypokalemia or resistant hypertension. This is again the international recommendations. We try to raise the potassium level, and we try to lower the blood pressure level, but in the common clinical experience as well in the literature, we are not bad at correcting the potassium level, but not very good at correcting the blood pressure in the long term. So imagine the normal gland here, you see the right and the left, there is anatomical variations. Usually the left adrenal is larger than the right, so you have to know that before you try to understand these images. This is small images with small glands, so it's not so easy to diagnose. So the typical aspect of the Conn disease on CT is a small tumor which has a low density pre-contrast, little contrast uptake, and has a positive and early washout. So this is pre-contrast, early arterial phase. You see the aorta is completely white, and then if you wait for 5 to 10 minutes, then it will go down relatively rapidly as well. So it has a very good sensitivity and specificity. And again, you can calculate this washout. This is a complex, not so complex formula, but you need to calculate this IV, 60 seconds, 10 minutes, and you can calculate this washout, which has, as you see, very high sensitivity and specificity in the diagnostic. Same thing for MR. MR, you can use these inversion sequences, where you can see that there is a decrease in intensity in phase opposition imaging, which will help you to diagnose the fact that this tumor is benign and not a cancer. So if you take home points on these adrenal imaging things for you to remember for tomorrow, a mass with a spontaneous density of less than 10 units or significant washout, you don't need to do more imaging. A mass of less than 2 centimeters without known cancer is not a metastasis. And if you have a large tumor, then you have to go further, whether it's surgery or more imaging. So in conclusion, ladies and gentlemen, I think that CT and MR plays a key role in the workup of secondary hypertension. We all know that. I don't think it's in competition with duplex. I think it's complementary to duplex. Whether we would like to do it before or after, this will depend on the local setting. I think more work has to be done on that. Obviously, this is a joint work between dedicated clinicians to filter the indications. I don't think we will do imaging on all patients. And obviously dedicated radiologists, because you have some knowledge behind all this. Thank you very much.
Well, other questions?
I have a question. Do you think that the quantification of the amount of narrowing and what you said about all the different diaphragms in fibromuscular dysplasia is really necessary? In my view, this is a disease which can be, which looks like a watering pipe. If you have multiple narrowing, at the end you will have a falling perfusion pressure, and there is unequivocal evidence that you need to do something in that case, particularly in young people with no other causes for hypertension.
In the old days, with Andreas Grünzig, we measured actually the gradient with small catheters. But I think the duplexes are actually better there, because there you see whether